Good morning. My name is Diane Borkowski. I'm the clinical specialist with Thermo Fisher Scientific, and this morning I'd like to introduce Dr. Eric Gluck. He's the director of critical care at Swedish Hospital and a professor of medicine at Rosalind Franklin of Health Sciences at the Chicago Medical School. He's board certified in internal medicine and specializes in pulmonary and critical care medicine. Dr. Gluck was named Fellow of the Society of Critical Care Medicine and the American College of Chest Physicians for his significant contributions to the advancement of pulmonary and critical care medicine. Dr. Gluck co-authored the 2013 pilot publication setting the foundation for the multi-center Moses trial, which resulted in the expansion of the Procalcitonin FDA claim back in 2016. He continues to share his expertise among his peers in the critical care community and has been invited to provide hundreds of academic lectures both nationally and internationally on many topics including sepsis, biomarkers, and procalcitonin. Dr. Gluck was an early adopter of procalcitonin both in the U.S. and at his own institution. Procalcitonin is now incorporated in the training curriculum of new physicians and is part of the daily medical management decisions of patients with suspected or confirmed sepsis. Welcome, Dr. Gluck. Thank you.
Wait till you hear what I have to say before you applaud. If anyone thinks that there is no difference between a frail patient and a non-frail patient, all you have to do is go back to the COVID epidemic and you saw blatantly what the difference is. I think they chose me to do this speech because I'm approaching the frail patient level in my physiology. But there is a difference, and we're going to talk about that, and it's really important that we recognize it. And so basically, what are the challenges in dealing with what used to be called the elder population, but we now identify them as the frail patient? And of course, probably the most important thing for everybody to realize is that there's a difference between physiological age and chronological age. Our surgical friends knew this long before us because they knew that surgical healing was way different in the elderly patient than in the younger patient, despite the same surgery and the same amount of tissue that had to be interrupted. So we're dealing with functional differences, cognitive differences, and of course, both of those sort of play together. And I think everyone in critical care sort of knew that one of the most important criteria for whether somebody was going to leave the ICU after being treated in the ICU was how well they were doing before they got ill. And so the functional status prior to coming to the ICU was a big deal. Now we're going to put this in this specific perspective. These patients do have cognitive difficulties. And the brain physiological interaction is still being understood and probably does play a significant role in how an elderly patient responds to illness or a frail patient. There are different biological mechanisms we'll talk about. The stress response is slightly different. And typically these patients have multiple morbidities, something that is really different and distinct than the non-frail younger patient. One of the most important things that we're going to be talking about today in our understanding of how to deal with frail patients, especially sepsis, is that we are now identifying that there is a different immunological response that occurs with age, which probably is what makes some of the elderly patients frail. And there's a less pronounced immune response. They don't respond as vigorously. But more importantly, the response is different. It's more global. It's not as specific to the specific organism that's invading their body as a younger patient. They seem to have a much significantly elevated incidence of systemic infections, where many of us might get an infection and control it locally. The frail patient does not. And they tend to run a more severe course of the disease for multiple different reasons. So, this frail group of patients does have a significant increased incidence of infections. In many series, sometimes as high as 20 times the basal rate for the non-frail patient. In urinary tract infections especially, community-acquired pneumonia about 6 times higher than the basal rate in the community. They are more likely to be hospitalized for pneumonia than a non-frail patient, and that is not a typo. That is 53-fold. Once they're in the hospital, they are more at risk for nosocomial infection, so getting them out of the ICU and elsewhere is more difficult. They are more likely to have bacteremias, although that's always a difficult analysis to make because finding bacteremias in anybody is sort of a random event almost. They do get frequent recurrences, more so, and that may have to do with that immunosenescence that I mentioned before. If they do get infected, their local healing ability has changed. And that could be the source of a whole new lecture on how elderly patients and frail patients heal. But they're more likely to get perforations and abscess formation. They are more likely to get renal dysfunction in two manners, one directly from the illness, and two from the treatment for the illness. And they're more likely to get organ dysfunction, and as a result of all of these things, mortality is significantly higher given the same infection in a frail patient. So, besides the actual infection that does the frail patient some harm, we do need to worry about adverse drug reactions. They are significantly more likely to get cardiac interactions, hepatorenal interactions, and C. difficile. They're more likely to develop and be colonized with multi-drug resistant organisms, and develop antimicrobial resistance or be infected with, more likely being infected by an antimicrobial resistant organism. Resistance developing in a patient during an illness is pretty a rare event. The other problem that we have is identifying the frail patient when they're ill. They don't have the same kind of response that younger, more robust people have. Often no fever. They sometimes present with completely tangential symptoms like delirium or just a fall. Very common presentation, patients with urosepsis. There's a patient who had a syncopal or near syncopal episode, most likely due to hypotension and sudden change in positioning. They also have chronic illnesses, and often when they get infected, the chronic illness gets worse and then clouds our understanding of what's really going on. We're looking at the renal failure that got worse, and instead of pursuing the possibility that something is making that worse, we're looking directly at that. They do get an over-response, as I said before, of these non-specific inflammatory mediators, CRP and IL-6. These markers are about inflammation and not specific to infection, although they do go up in infection, but they are going up in infection because of the inflammation. We'll talk about that in a little bit. But they get a robust response, and that causes other tissues to become inflamed as well. And then trying to use SIRS criteria, QSOFRs and NEWS criteria in these elderly patients is fraught with difficulties. They tend to overreact to some of these things, but also many of them are on beta blockers. And if you put a patient on a beta blocker, all of the responses that we typically see when somebody's in septic shock or severe sepsis are blunted. And so the body is not reacting in its symptomatic response to the infection as it normally would. So the object of treating infection in everybody is the right drug for the right patient. So one of my mentors from a long time ago basically said when you have a patient who's very, very ill, you don't need a lot of antibiotics. You just need the right antibiotic. And that's what that first statement is. It's the right drug. It's the right person. So a community-acquired pneumonia in a patient who's in shock doesn't require 12 antibiotics. It just requires the typical antibiotics for community-acquired pneumonia. But the key thing in the frail patient, it has to be the right patient. We need to be treating only the patients who are infected, and we need to be treating a patient who's infected as quickly as it's possible to make that diagnosis. And we need to give it for the right duration. Any additional duration of antibiotics will have significantly more side effects in the elderly patient. And that's where the right duration comes in. Okay. How many people here are using PCT in their hospitals right now? Okay, good. So this is going to be a little bit redundant, but I'm going to do it anyhow because I love this part of the lecture. So this is speaker's choice. So everybody, maybe you don't know, procalcitonin is sort of an interesting thing in medical school. Everybody's still taught that it is involved in calcium metabolism. That's what it's there for. It's the yin to the pro-parathyroid hormone. That's how it was discovered, but as it turns out, that's probably not its original intention in its role. In fact, we know that it has a minor role in calcium metabolism even now, because if you do a thyroidectomy on a patient, the major source of procalcitonin for calcium metabolism is removed, and nothing happens to your calcium. Unless, of course, the surgeon takes the parathyroid hormones with it. Then that's a problem. So this is an interesting thing. It's this amino acid chain is cleaved in two spots, which makes it really unique. It is released after cellular stimulation, and we'll show you how the cells get stimulated. And it doesn't have to be living bacteria, which is a good thing, because if the body has taken care of some of the bacteria somewhere and a dead bacteria or even part of the bacterial wall floats by, it will stimulate a response to let the body know that there's a bacteria infection somewhere in the vicinity. We now understand that it's a very specific marker for bacterial infection. There are very few things other than bacterial infection that can actually cause its release. We can discuss that later too if we want to. Key thing to remember, it basically is a marker of the body identifying that bacteria are somewhere where the body doesn't want them to be. That does not actually always mean that you need to treat it. It just means that there are bacteria that are not where they're supposed to be. And most of the time, as you'll see, the body can take care of these bacteria, but when it can't and the levels rise very high, that's when antibiotics are absolutely necessary. Another key thing is that it does correlate with bacterial burden. And so the higher the levels, the more bacteria that are present, and therefore it will tell you when infection is there, and its disappearance curve will tell you when you're successfully treating it, which is a good thing. We know that in this thyroid gland, the C cells produce procalcitonin. There it is broken down into calcitonin, but in all the other tissues except myocardium, the procalcitonin is metabolized differently into, because it's not broken down to calcitonin and is released as procalcitonin. This rather complicated slide basically shows what our body does on its own. And this will take care of about 99.3 or 4% of all the infections in our body. So it is less than 1% of the infections that somebody is going to get ill enough to want to be treated by somebody or to show up in the emergency room and definitely to get into the ICU. All of these infections with bacteremias and things like that that occur on a daily basis when you do flossing your teeth and things like that are taken care of by our immune system through neural nets and all these other metabolic pathways. When there is a bacteria, the cells have these toll receptors on the outside, and these are like antennas that are searching the environment for live bacteria, dead bacteria, or even parts of bacteria. And as soon as they detect that, a chemical reaction occurs. And this chemical reaction, these are the toll receptors over here, are going to cause a marker to go into the nucleus of the cell. It then binds with the DNA. The DNA unfolds. It makes procalcitonin messenger RNA. The messenger RNA gets out into the cell. The messenger RNA then is used as a template. We make procalcitonin, and when the levels get high enough and they spill out of the cell, they are detectable. And so there is an inherent delay between cell stimulation and procalcitonin production. And it's probably somewhere around 4 to 6 hours. So this is my rendition of what happens. That green fuzzy thing is a bacteria. That purple thing underneath it is the toll receptor. The bacteria stimulates it, and then initially the non-specific inflammatory markers that are in your cell are released. That's the TNF, IL-1, IL-10. All of these are prepackaged in the cell. We always have them. They're there ready to go. And that's what causes actually the fever, the tachycardia, the tachypnea, all those things that we associated with infection. But they're very nonspecific. At this point in time, the body is telling us we're inflamed. I don't know what it is. I'm hoping it's not a bacterial infection, but if it is, I'm ready to defend myself against it. So the default is bacteria. After a period of time, it then will actually identify whether it's inflammation or bacteria. Can't get behind the 8 ball with a bacterial infection. Those bugs are doubling every 20 to 40 minutes. If you wait too long to start fighting that infection, all is lost. So the body hedges its best, and it always assumes bacterial infection with the inflammation. And then once it identifies that there's no bacterial infection, because there is no production of procalcitonin, it then goes into the anti-inflammatory response alone. And so here is the depiction of these squiggly lines being the messenger RNA, attached to the ribosomes, and then the procalcitonin being exuded from the cell into the serum. And then when it goes into the serum, it is a warning system to the rest of the body. So this is identifying a non-contained bacterial infection. We've gone beyond the local defenses. I have a non-contained, I need help. And so it's going to go to the liver and get the liver to turn on its immuno response, the spleen, the adrenal gland, the brain, the heart, and every other organ that has receptors for it to help defend against this infection. This is the depiction of the kinetics of the inflammatory mediators that we talked about. And you can see that the ones that I said were the ones that were prepackaged. They come out right away. IL-6, IL-10, TNF, IL-1 is not there, but those are the ones that are responsible for identifying the typical SIRS criteria that you are aware of. And that's why at the bedside, it is so hard in the initial phase of a person like this to differentiate between something like sterile pancreatitis and a pancreatic abscess. Because the body is not differentiating it. The body is saying, I'm going to hedge that it might be a bacterial infection, and then I'll figure out what to do a little bit later. When you use these markers, you can see the sensitivity and specificity of procalcitonin is significantly better than the other markers. Whoops, I didn't mean to do that. CRP is a great marker for inflammation. No ifs, ands, or buts about it. It's a terrific marker for inflammation, but it is not specific for bacterial infections. So it will go up whether there's a bacterial infection or not. It will come down when the inflammation from the bacterial infection goes away, but it comes down much slower because the inflammatory process takes longer to get rid of than the actual bacterial infection. IL-6 is very similar. Lactate is on this chart. This was from an article by Mueller that was published in Critical Care Medicine quite a while ago now. That was unfair. Lactate is a marker of something different. It is part of the sepsis response, but it's also a part of a different response. And it's really more about adequacy of perfusion on a global basis. So it does look bad there, but it is absolutely necessary, and there is no way that you can separate the two. You have to use both in order to identify what's really going on. This slide depicts the dose response curve, if you'd like, between procalcitonin levels and bacterial burden. And actually, the more bacteria you have, the more likely you ought to go to septic shock, and you can see the different ratios. Now, this is a great marker when you think about it. I mean, the normal range is less than 0.05, and somebody with severe sepsis has a level of 10. That's 1,000 times higher, 2,000 times exactly. That's a really nice differentiation. Makes it less likely to get false positives and false negatives. I had no place else to put this. This is the normal rise of procalcitonin in 3 different groups of patients. The blue line represents the normal response to somebody who has sepsis who you've given appropriate antibiotics. So this patient would present over here, And then for 24 hours, the level still can go up. That is not identifying a patient whose antibiotic therapy is inappropriate. We are making this, once the messenger RNA is made, it will continue to make procalcitonin until it disintegrates. It doesn't stop. There is no mechanism to say, no, we don't need it anymore. And so it will rise even if we are treating the infection appropriately for the first 24 hours usually. And then the half-life is very nice. It's about 50% per day, unless you have renal failure. If you have renal failure, then the rise is often delayed and can go up for about 48 hours. There have actually been reports that it might go up for almost 72 hours. And then when it goes down, the half-life is it's about 30% reduction per day as opposed to 50% per day. And this is the person in whom you're not appropriately treating the infection. The levels will continue to rise until the patient expires. Okay, so that was the fun part. Now we're going to get into the data. You guys came here to hear the data, and you're going to have to go back and convince your colleagues, if they're not using procalcitonin, that I didn't make all this stuff up. So here it is. One thing I want to let you know, I took this from a presentation. In the United States, procalcitonin is not approved for use in children. And so do not look here or over here. Okay, I promise. Okay. Basically, what this is a group of studies, all of which showed the same thing. It is funny that procalcitonin had a very bumpy road in the beginning. It took forever before there was a buy-in that this marker actually did something useful. There are over 1,500 papers published on procalcitonin, and 98% of them are positive, 2% are negative, but 1,500 papers. There has never been a biomarker with more papers than procalcitonin. Not exactly sure what the deal was, but nonetheless, there are multiple studies here, and they all show the same thing, that if you use procalcitonin as your identifier of a bacterial infection, then you can safely not give antibiotics to people whose procalcitonin levels are negative, and you will not get any additional adverse events, no additional mortalities, no additional length of hospital stay, and no readmissions. The most impressive one of these is the first paper by Schutz. That was the one that was published in JAMA. Can't remember what year it was, but there was about 1,400 patients in that one. What was elusive for a long time was mortality benefit. It didn't make a lot of sense. I mean, if we could identify infections faster, and we would treat them with the appropriate antibiotics because we could actually identify when we weren't, and we wouldn't overtreat them with antibiotics for a prolonged period of time, why weren't we seeing a mortality benefit? And as it turns out, part of the reason is that, fortunately, mortality rate for sepsis and severe sepsis and septic shock has gone way down. I will now tell you through indirectly how old I am, because when I was a resident, the mortality rate for septic shock was 90%. And now the mortality rate for septic shock is less than 20%. And so because septic shock and sepsis and community-acquired pneumonia mortality rates have gone down so fast and so dramatically, it has been difficult. But here, what was done is there are multiple different studies which basically looked at various different types of infections: respiratory, urinary, abdominal infections, skin and soft tissue, which did include flesh-eating bacteria, central nervous system infections, which you can see had a pretty significant odds ratio reduction. Overall, we now have data that supports a mortality reduction in using procalcitonin in this manner. Now, I always thought that using the Q-SOFA and the SOFA and those things, which were really actually created for something else to identify the presence of sepsis, was a silly idea, but nonetheless, a lot of people do. We need some objective markers about how sick somebody is. Unfortunately, in our patient population that we're talking about today, the frail patient, you get a lot of points for being old. And because of that, it skews the results. And there needs to be a better identification, and we do have it now. We have frailty scores, better than just looking at age. Because, like I said, there's 85-year-old patients who are tremendously robust and are really chronologically behaving like they're 55 or 60, as opposed to some who are severely impaired. So basically, this was a comparison of how well did the Q-sulfur and sulfur predict sepsis and outcomes in the emergency department compared to procalcitonin, and you can see that the area under the curve for procalcitonin is significantly better than the SOFA score, and the Q-sulfur score, I don't know what the people in this room have felt about that, but I'd never had the ability to get that to work for me at all. Certainly is easy and might work as a pre-warning system for patients at the bedside, but as an identification of sepsis, it really was not very good. Being a pulmonary critical care guy, acute exacerbation of COPD, the bane of my existence, because you can't tell if they're infected or not. They come in and they cough. They don't usually take their temperatures. They don't come in with CBCs and differentials and things like that. Even if you ask them if their sputum changed in quantity or color, that correlation with actual infection has been demonstrated not to be very specific nor sensitive. So it turns out, when in doubt, what are we going to do? Well, we're going to treat with antibiotics. And so when acute exacerbations, COPD occur, and this is the season, I'm hoping that this will be less of a problem for you younger people in the audience because less people are smoking. We're finally seeing a significant reduction in cigarette smoking. I think the last thing I saw was less than 15% of the population, compared to when I was a rookie, about 38% of the population. So this is good news, but they're still going to come in with acute exacerbations, and identifying who has an infection is really important. As it turns out, 90% of the patients who show up with an acute exacerbation will get antibiotics, yet studies have actually shown that only half of the patients who show up are actually infected. And so can we get the right drug into the right patient at the right time? And as it turns out, procalcitonin in many of the studies that I had shown before are able to identify those patients. So patients whose PCT less than 0.25, don't really need to give those patients antibiotics. Patients whose PCT is greater than 0.5 probably do need to give antibiotics too. In the middle, clinical correlation. But also identifying the duration of therapy is very important as well. So now, it was sort of interesting, right before COVID came, we had noticed that lots and lots of patients who came into the ICU with severe respiratory failure tested positive for influenza and also had bacteria in the sputum. And I mean, it's not impossible to have a co-infection, but it's more common and more likely to have had one than the other. As it turns out, influenza positivity can continue for 2 or even 3 weeks after the infection. So if a patient shows up with a positive influenza screen in the emergency room, that could have been from an infection they had 2 weeks ago or from the infection they had now. And it is also possible that they've had influenza for a few days and then they have a co-infection. And so at that point in time, we started using procalcitonin as well as this indicator. And if they showed up with this kind of presentation and the PCT levels were negative, we assumed that this was an influenza infection. If the PCT levels were positive, then it was either an influenza and a bacterial infection or just a bacterial infection. And we found that to work out really, really nicely. This was borne out during the COVID infection, which I am not going to show data for, but the same thing was held true in the COVID when we adapted. So when you look at the analysis In this patient, this was a study from Spain. They looked at almost 1,000 patients, and they looked at the ability of Procalcitonin and CRP to identify who might have bacterial superinfection or co-infection on influenza. And they found that Procalcitonin actually was a very useful marker in these instances. So we continue to screen that way, and that has been adopted into my intensive care unit. So if a patient comes in with infiltrates and respiratory failure, we will test them for both influenza, still sadly for COVID. Occasionally we do a full respiratory panel and then PCT. This has also been shown in this study by Christensen to be useful in patients who are hospitalized. So this was a single center study. This was from Norway. It's a small study, and again, just additional information that suggested that using Procalcitonin in this manner was useful, especially, but mostly actually, in its negative predictive value. Positivity was a bit problematic. You can see that the sensitivity and specificity for positive was not great, but the negative predictive value is terrific. So if you have a patient who you think might have a bacterial infection versus a viral infection, if the PCT is negative, antibiotics are probably not necessary. They use the cutoff of 0.25, which is pretty typical for what everybody does use. It has been demonstrated that older patients, and I think I showed you that slide earlier on, do have a higher propensity of getting bacteremias. It's probably because of the immunosenescence and their inability to contain those infections on a local level, so the bacteria are more likely to get into the serum and create a bacteremia. We can identify bacteremias, the probability of bacteremia, with a little bit of higher success if we use Procalcitonin. So in this systematic review, this was 58 articles. The vast majority of the patients were not the frail patient, but there were patients in the 77, up to 77 years old, so it did include some frail patients, and it basically demonstrated that a higher level of Procalcitonin was associated with a greater likelihood of bacteremia. Nothing we need to really change our practice about, because basically we are required to get cultures on all the patients who present with sepsis anyhow. So, but it just tells us whether we're more likely or less likely to see that. Okay, so now we've sort of identified the bacterial infection. Can we use this marker, and do we need to use this marker to manage the infection in the individual patient? Now, most of the regimens that we used, and we are using now, were created 30, 40, 50 years ago. And it was basically a great empiric guess. Yeah, this infection needs 7 days, this infection needs 14 days, this infection needs only 10 days. There were very few. It's either 1 week or 2 weeks. There were a few that were 10. And then you have the really bad ones that require 6 weeks. But of course, that was the best they could do then. They didn't have a biomarker that could actually individualize the therapy to tell which individual patient really only needed 5 days or 7 days or 10, or which patient who you were going to give 14 days actually needed 16 or 18 days. We didn't have those markers available, but we do now. And we are estimating that more than 2/3 of the patients are getting more antibiotics than they actually need. And studies have shown that each excess day of antibiotic treatment is associated with a 5% increased risk for an adverse antibiotic reaction. The mean antibiotic duration in CAP is 11 days. If you read every single medical textbook, we're supposed to treat CAPs for 5 days, but they're getting 11 days of antibiotics. And often it's because they're in the hospital for only 3 days, and they go home, and we write them out a script, and we're not going to see them, and we're anxious about what's going to happen to them when they're not under our watchful eye. But this is associated with significant increased cost and especially in the frail patient, with increased risk for morbid reactions. So there have been multiple studies. I just picked this one to present, the ProPage study. It was a multi-center. There were 107 patients in the group that were over the age of 80. This was a comparison to control group, which was the usual therapy, which is almost what all these studies always show, versus a procalcitonin algorithm. The antibiotic therapy in the control group was clinical presentation, which is basically clinician's choice. Whoever was taking care of the patient, be a nurse practitioner, doctor, medical group, or what have you. And the pre-CT group had an algorithm. And here's a kind of interesting thing. This is one of the few studies where they didn't actually measure procalcitonin daily. So I know some of your CFOs at your hospital may get anxious about doing daily PCTs on a lot of patients. This one measured it every other day. And if you do some good extrapolation with your curves, it's probably reasonable. And this is basically what they showed, that they could significantly reduce antibiotic therapy in this group of patients by 2 days. And here's the interesting thing. They did it with 2 days under adverse conditions, because only 50% of the time was that algorithm followed for the procalcitonin. That could have been significantly better. But there were clinicians who basically sort of opted out based on their clinical judgment. One of the other things that I don't get to see very much in the ICU for urinary tract infections, but I do morning report with my interns and residents, and this I see all the time, is asymptomatic bacteria. Estimated to occur in a huge portion of our elderly patients and our frail patients. Definitely overdiagnosed. Once again, it's physician and nurse practitioner and other healthcare provider angst. See the patient, see this thing, don't know what the patient's going to do. Is the patient going to call me in 2 or 3 days? Is the patient not going to call me in 2 or 3 days and show up in the emergency room 5 days later in shock? And so there's a tendency to overtreat. And again, can we do better with procalcitonin levels? And the answer is actually yes. This was specifically a patient study in elderly patients. These are patients who are older than 73. I mean, the median age was 73, excuse me. Again, standard medical practice versus algorithm. And then they treated the patients who had an infection until the PCT went down to 80%, less than 80% of predicted. And basically, you can see all the different antibiotic stewardship patients with urinary tract infections. Here, there were complicated febrile pyelonephritis, there was regular pyelonephritis, simple UTIs, the whole gamut of anything that you could think of involving urosepsis. And the procalcitonin guided reduced antibiotic therapy by about 30%. There was this became true across the entire gamut. There was no impact on mortality. There was no persistence of infection, something we're always worried. The recurrence rate was exactly the same, and there was no rehospitalizations. Okay, so to summarize and leave some time for a question or two, sepsis significantly impacts the elderly patient, the frail patient. 20 higher fold. I had no idea before I started talking and thinking about this. We have a paper that we're producing right now that deals with the frail patient and infections. The clinical presentation is really misleading. You have to check their drugs that they're taking at home. If they're on a beta blocker, it's really difficult to identify the signs and symptoms of sepsis in them. So it's really important to understand that. And they do have unusual presentations, sometimes completely unrelated to the site of infection. Patient monitoring is really, really important. Giving the right amount of antibiotics to the patient for the appropriate day and avoiding antibiotics in patients who don't need them is really significantly more crucial in this population than any other population. They do have a higher likelihood of developing C. diff, Of course, we get dinged for that. Resistant organisms have a higher prevalence. They will get kidney failure and diarrhea, and they're on a long laundry list of other infections. And so figuring out whether they were having an interaction between antibiotics and the other drugs is also problematic. It's pretty easy for the pharmacist to do when there's 2 or 3 drugs going on, but if you have 18 drugs, which is not an impossibility, if you actually try to figure out the number of drug-drug interactions with 18 drugs, there are more drug interactions in that than there are stars in the known universe. So think about that number and ask your pharmacist to figure out what's going on. It's not easy, and the only way to deal with this is to ensure that every time we give antibiotics, it's appropriate. I think I skipped this. This one I want to show. This is going on with the adverse event. You can see that in the first slide, when the algorithm was followed, the actual use of antibiotics was reduced in half, and then you can see the number of C. diff infections was significantly reduced, and also the 28-day mortality was reduced. Okay. And I think I sort of did that already. Thank you for your attention.